And the sad thing about brain tumors is they grow inside the skull. Even if it's benign, it can kill you.
It can be misdiagnosed as depression, but actually patient might have a brain tumor.
That nobody paid much attention to.
When we find out about these symptoms, right, is it potentially too late?
Brain tumor is not a death sentence. There is hope.
And it's progressive. Go and get help.
Dr. Alinda specializes in modern radiotherapy techniques including stereotactic radiosurgery and stereotactic body radiation therapy, alongside chemotherapy, targeted therapy, and immunotherapy. Dr. Vineswaran Martinezwaran is an experienced neurosurgeon and former professor of neurosurgery from the University of Malaya with over 30 years of clinical experience. He is also a big advocate for the multidisciplinary team approach, ensuring patients receive holistic care and treatment. Brain tumor accounts for around 2% of all cancers in Malaysia. And while that sounds like a small number, brain tumors are a debilitating disease that causes a tremendous amount of burden to patients, family members, and the healthcare services. Hi, my name is Leonard, and welcome to Let's Talk About, a health podcast by SJMC. Today, let's talk about brain tumors. Now, joining me today is Dr. Vineswaran Martinezwaran, a highly regarded neurosurgeon and surgical innovator with over 30 years of clinical experience, and Dr. Alinda binti Alip, associate professor and consultant clinical oncologist who specializes in modern radiotherapy techniques, including stereotactic radiosurgery and stereotactic body radiotherapy, alongside chemotherapy, targeted therapy, and immunotherapy. Doctors, pleasure to have both of you today. Welcome.
Thank you very much.
Thank you. Pleasure to be here.
So I want to get the ball rolling on brain tumors, right? I think as I just mentioned in the intro, it looks like, at least according to the National Cancer Registry so far, it doesn't sound like it's a very frequent cancer that we see. Why is shedding light on brain tumors important, just to get the landscape correct? What do you guys think?
Definitions are important. And here we are talking about brain tumors. Now, brain tumors are actually primary and secondary. So you're speaking only about cancers. But when you talk about tumors, they also include benign tumors. And the sad thing about brain tumors is because they grow inside the skull, even if it's benign, it can kill you in short order. And also, the numbers may not accurately reflect the number of brain tumors that actually occur because we missed the benign tumors that can be very dangerous. And they're also subject to similar treatment like radiation. And we also possibly miss the metastatic tumors, which are tumors from other parts of the body that spread to the brain because they may have already been reported as a breast cancer or a lung cancer, one of those things. So actually, I think the number 2% may not be truly reflective.
Right. So there's probably a lot more cases, even just on its benign level at its
absolutely.
own, right?
Yeah.
So for people who perhaps don't really understand what brain tumors are, we've sort of alluded there are different types of brain tumors, but let's help the audience understand, right? How would we go about explaining brain tumors, and in what ways do they impact Malaysians the most? I think we can all think of cancers and death, but how do brain tumors actually impact individuals as patients?
So as I mentioned a little bit earlier, you have benign tumors and you have malignant tumors, okay? Benign tumors of the brain generally grow from outside the brain, pushing the brain, but they occur within the confines of the skull. So benign tumors can kill you also by raising the pressure inside the skull. In addition to that, benign tumors can cause serious amounts of problems when they compress important structures of the brain. So for example, if you had a tumor located in the left side of your brain, depending on where it is, it could affect your speech, it could affect the motor on your right side, moving your hands and legs, yeah? Or some of the more benign tumors like schwannomas that occur on your eighth cranial nerve can affect your hearing and can compress on your brain stem, and all this can maim you and kill you. Then there are cancers of the brain. These are primary brain tumors, and they occur within the substrate of the brain. And usually they are not so discrete, and they kind of spread following the nerve fibers in the brain. And then we also have other tumors like pituitary tumors and all that are actually technically outside the brain, but they produce hormones and they can cause a lot of disruption. And when some of these tumors become very large, they can compress your optic nerve and chiasm and can cause you to have blindness, or you lose part of the areas that you can see.
Right. So, and from the world of oncology, we talked about malignancy in a bit, right? Are there different types of malignant brain tumors that you see, Dr. Alinda?
Dr. Vigneswaran just talking about primary brain tumor just now. So maybe I talk more about secondary brain tumor. Like I mentioned earlier, it comes from other parts of the body. So mainly from lung cancer, breast cancer, can be from other cancers as well, kidney, colorectal, but perhaps less common. Patients are survive longer. There are a lot of new treatment. So the longer they survive, the chance of the cancer to metastasize to the brain or spread to the brain will be higher. And a lot of treatment, systemic treatment like chemotherapy, is not able to penetrate the barrier to the brain. It's important to detect early and also treat early if it's spread to the brain.
Right. And I want to talk about treatment in a short bit. But before we go into there, when it comes to a lot of cancers, there are screening tools, you say, there are blood markers. For example, you've got, different type of swabs and things like that. But when it comes to brain tumors, right, both in the primary and secondary level, are there ways that people can get screened? Are there ways? How do patients get diagnosed with brain tumors?
There are some people who may say, oh, we can do CT scans, but how often are you going to radiate the brain? Or we do an MRI scan, but how often are you, again, it's very cost inefficient. And there are no blood markers or anything like that. Of course, some of the cancers that spread from elsewhere to the brain, you may be able to pick it up based on the marker that goes up. So, for example, colonic cancers or prostate cancers, if your numbers start to go back up after you've had your initial treatment, would suggest that something is spreading somewhere. Okay, so there are no markers as such. So once you start to develop symptoms, say if you have headaches that seem to be getting progressively worse, it's not headaches of 1 day, 2 days, it's headaches that last for a few weeks and it seems to be getting worse, and there are certain characteristics of the headache. For example, morning headaches, then maybe it needs to be checked out. If you suddenly find that progressively you're becoming clumsy, or if you're younger and they find you to be slowly becoming forgetful with abnormal behavior, perhaps it should come to the attention of a doctor. So a necessary test, you can be examined first properly, and then necessary tests be carried out.
Right. So typically then what you're saying is, if you got new symptoms out of nowhere and they're persistent, I think the keyword is that, right? Then go and get...
Yeah, persistent and progressive, yeah.
Get a doctor to check it out, get a referral to a specialist if necessary. Yeah. But Dr. Linda, when it comes to secondary brain tumors, right, how are these typically detected? Are we able to pick it up earlier?
Actually, it's the same because it's in the brain. So the symptoms and signs, secondary and primary, will be the same. It depends on where the location is. I mentioned earlier for lung cancer, there's like up to 40% chance of brain metastasis. So when we diagnose patient with lung cancer, even if it's early stage, we would do brain MRI to make sure there's no spread to the brain. Nowadays, patient with stage 4 at diagnosis, for some patients, we do brain MRI just to check their brain if there's any spread to the brain, because that will dictate, how we treat the patient. But for other cancers, actually, it is based on their symptoms. So sometimes patient has diagnosed with cancer and then subsequently develop brain mass. But other times, they actually present with symptoms from the brain and they diagnose with brain mass.
So sometimes the patient doesn't even know they have an existing cancer first.
Yeah.
They come in for the brain, and then they find out about the lung cancer.
Yeah, and sometimes it can be misdiagnosed initially. Like, they see their local GP, might say it's migraine, or they might be diagnosed with stroke. That can happen. I mean, the diagnosis, whatever it is, the symptoms doesn't resolve. It's important for them to get second opinion.
So symptoms are clearly very, very important, right, to people listening in today. When it comes to a lot of cancers, it seems like a lot of the times they're picked up relatively late, stage 3, stage 4. You mentioned about symptoms, right? When we find out about these symptoms, right, is it potentially too late?
No, they're not. Because a large chunk of brain tumors are non-cancerous, right? So we have to, as I said in the beginning, we have to distinguish between a malignancy, cancer, versus benign, right? So a lot of patients who have benign brain tumors, for instance, the tumors can be resected And or we remove large chunks and then we send it to someone like Adlinda to give radiation on the remaining benign tumor. And the patients can return to normal life. And that happens very frequently, right? So when you have the symptoms, it's not a death sentence. It's not the end game. So if it's a benign condition, you can treat it, right? In addition to that, there are certain tumors like germinomas, for example. These are germ cell tumors that can occur and they respond very well. Once we do a biopsy and they give some chemotherapy and radiotherapy, they respond very well to treatment today. Even the cancers of the brain, when we find out that they are low grade, they can go on for many, many, many years. So a lot of the symptoms can be relieved by a combination of surgery or surgery and radiation, sometimes surgery, radiation, chemo.
I wouldn't say if patient has a lot of symptoms, diagnosing too late, because sometimes they can have small tumor, but a lot of swelling around it that cause more symptoms. So I think whatever it is, if they have symptoms, they should seek medical attention. Better to diagnose early so that we can treat early and prevent worsening of the function and symptoms and poorer outcome of the cancer or tumor.
Right, but even with symptoms and we're picking them up, it's never too late. There's still a lot of treatments available from what I'm hearing.
Because sometimes the symptoms come on very gradually, right? So I've had a number of patients over the last 20 odd years who presented with gradual change of their personality.
Oh.
That nobody paid much attention to, okay? Some of them were in very high-powered jobs and they suddenly decided as progressively they wanted to give it up or something like that.
Okay.
But nothing is more interesting than a lady from Kota Baru years ago. So she came to me and she had a huge brain tumor, which we resected with no issues. And then she went back home. And about 5 years later, and I saw her and I asked the husband, so how is she now? Blah, blah, blah. And all that. Oh, then any difference from before? And he says, oh, she likes using makeup right now after this. So I said, oh, does that mean that she was not doing it before? She said, no. She used to like dressing up and putting on makeup. And then slowly over a period of time, all this disappeared. Okay, she wasn't interested in self-care. And then once the tumor came out, she's gradually returned to her previous self. Yeah.
That's very interesting. It sounds...
Yeah. So sometimes, especially these days, we tend to write it off as dementia because there's so much of say on dementia. So not everybody is losing their mind or having some abnormal behavior is having dementia. Some of them...
It's really hard to pick up, isn't it? Because I could just be going through a phase.
You could. But if it's persistent and it's going on for a while and the phase doesn't... But even if you're going through a phase, you should possibly see a doctor, possibly, right? And who knows, it may be... you may be depressive, really, yeah, and there may be treatment for that. But it also could be that something else is happening.
Yeah, because it can be misdiagnosed as depression, but actually patient might have a brain tumor. So any symptoms, I think that it doesn't make sense. I think you should seek medical attention. And the other thing is, if the symptom like headache is quite common, but if it's out of ordinary, if it's persistent or worsening, especially if there is another neurological symptom that occur, then definitely patients should seek medical attention.
Right. So seek medical attention. If it's still persistent, get a second opinion, go into a specialist and figure out whether it's something more serious. But
having said all that, 90% of headaches are benign. Yeah? They don't mean anything, right? Only 10%. But as Adinda has rightly pointed out, only about 10% of headaches are significant. Okay, and some of them are actually the ones where they are progressively getting worse. So as Adelinda mentioned, headache plus something else, headache plus weakness, headache plus abnormal behavior, something like that. You have to have it checked out.
Got it. So if there's persistency, but it also progresses. Got it. In some cancers like colon cancers, family history plays a risk factor, right? In the case of brain tumors, are there such risk factors? Because I was looking through some numbers, right? And at the moment, it seems to have a higher incidence in females, and cases increases with age, particularly in the 40 to 59 age group. Is that what you see on the ground? Are people as young as in their 30s coming to see both of you?
You can have brain tumors at the age of 6 months, okay? The female bit is hormonally related because some of the more benign brain tumors are also responsive to the similar hormones. So that's why the female preponderance is there. The age related, that's because cancers occur as you become older, right? But there are a few brain tumors that are genetically related. A few. For example, neurofibromatosis. You have multiple tumors of the skin or sometimes both sides of the ear and stuff like that. And that runs in families. Okay. Or like von Hippel-Lindau. These are tumors that occur and you can get cysts in your kidney, you can get tumors in your head, you can get changes in your eye. But these are not very common. But today, as we know, all tumors are genetic. It's just that we don't know what the genetic is or why did the genetic change.
But in that case, I would assume, Dr. Linda, that if because you mentioned 40% of lung cancers would eventually have metastasis to the brain, right? Naturally, with lung cancers, if my parents had lung cancer, I can screen for lung cancer, for example, or at least be a bit more vigilant about it.
Yeah, but lung cancer, the number one risk factor is smoking. But in Asia, like especially female, there can be like certain mutation, which is common in this part of the world. So my father had lung cancer as well, but I think it's from smoking rather than it's inheritatory.
Right. But I guess the question I wanted to ask then, if I know they are not the majority of cases, but if let's say my grandfather had brain tumor, for example, is there anything I can do to screen for it?
No.
So just wait for symptoms?
Yeah.
That sounds a bit scary.
No. No.
Because the genetic that runs in the family is very rare.
Yeah.
Hardly.
But if you had both side hearing loss and you got tumors in both ear, then I'll tell the rest of your family to get screened and look at their genes and things like that because you probably have NF.
Right. So maybe in that scenario,
that's
genetic
different.
test.
That's different. Yeah.
Okay, got it. So at the moment, there are no dedicated screening tools that people can do on the regular as part of an annual health screening. However, if symptoms do appear, they're persistent, they're progressive, get it checked out, get medical attention, seek second opinion if you need. Thanks for listening in, and I hope you're enjoying the episode so far. If you find the message meaningful, share this to somebody close to you or a loved one. So we've spoken about the different brain tumors. We've spoken about how it's presented. I want to talk about treatments now because, following from what I said about the taboos and everything, was it really a death sentence in the past?
Okay, so surgery remains the mainstay of brain tumor. Yeah, it's the mainstay. And when I first started, when someone went in for brain tumor surgery, they were prepared to die or they were prepared to have severe neurological deficit. Today, they come to clinic and they complain, doctor, I've got this little dent on the side of my head. Can something be done about it? Or my skull feels a little bit uneven. So, but that is good. That means the technology and the skill level and the delivery has evolved. That the complaints now are more cosmetic than serious. Okay. But I also say that neurosurgery is an unforgiving mistress. Okay, it's all nice and good, but when things go wrong, they go horribly wrong. So patients can have a lot of devastating issues. So I don't want to go off by saying that everything is easy. But the majority of patients come in, have the operations, and they go back within 5 days. Yeah, and then they may be then referred on to the oncologist to do their magic.
Yeah, when we talk about treatment, actually treatment is individualized. So, one person brain tumor or, metastasis is not treated the same way. So I remember I have a young guy, 40 plus. He had early lung cancer, operated. 2 months later, presented with weakness on one side and headache. And he had spread to the brain metastasis, 3 spots. So we treated with stereotactic radiosurgery. And then he had all the other treatment for the lung cancer. And that was like 6-7 years ago. Now he's free of any cancer. So when you say it's a death sentence, it sounds so extreme.
Right. But I guess even in your case, Dr. Linda, right, we get this all the time. Patients sees chemotherapy and they get really scared, right? And was it true that in the past we couldn't be precise? Is that true? And was the patient outcome significantly worse than what it is today?
In terms of radiotherapy,
chemotherapy.
I see the technology has advanced so much Last time we mainly give like whole brain radiotherapy, but now we have different techniques. We have stereotactic radiosurgery where we can deliver precise radiotherapy to where the tumor is. We don't treat the whole brain. Or if patient need whole brain radiotherapy, we can spare areas like hippocampus, which can spare or reduce the risk of
So you can
memory.
spare parts of the brain that doesn't need to be impacted these days.
Yeah.
Right.
We can minimize the side effects
Right.
of radiotherapy.
I just want to ask because on the note, and for the sake of the public, right? I know radiotherapy as radiation, right? But you mentioned stereotactic radiotherapy. What's the difference?
It's still radiation, but we use precise imaging so that we can target one area and reduce the dose to the surrounding brain. So that would allow us to give more dose to the area that we want to target, and minimize the dose to like other parts of the brain.
Right. So no longer are we in the era where we provide like blanket treatments, and it's really because of advancements in, I suppose, imaging today, you can pinpoint specific location. And because of that pinpoint accuracy, it sounds like you can also increase the dosage of the radiation so that it really targets that specific point effectively. Is that correct?
Yep. Increase the chance of really control the area and reduce the chance of side effects to the surrounding area.
Right. So help me understand, right, from a collective point of view, we're very lucky to have both a neurosurgeon and also a clinical oncologist today. Typically, if let's say a patient comes in and they've come in for brain surgery, but it sounds like they also need radiation, for example, how does the treatment plan come together typically in such a case?
So today, when we treat patients, it's actually a lot of teamwork involved. Okay, the teamwork involves not just the surgeon. The team must include, for example, the intensivist, the anesthetist, the dietitian, the physiotherapist, the rehab specialist. Okay, so that's the part of recovering from surgery, and then we discuss with the oncologist. So we have quite a lot of in-depth discussion, or can this be done? Can that be done? What we should do. Okay. Sometimes we have MDTs where we actually sit down and look at the scans and look at all the images and decide what best to treat this patient with.
So the multidisciplinary approach is very important in treating brain tumor or other cancers. Presence of neuroradiologists or radiologists who actually specialize in neuro is also important, and also the pathologists, because sometimes the diagnosis has to be like tissue diagnosis usually, so they will confirm whether it's brain tumor from the brain or from elsewhere. Yeah.
Right.
Yeah. But so I'm glad you raised this thing about pathologists, because previously they used to just tell us what cell type it was. Now they will go deeper and tell you what the genetics of this tumor is, or because that then determines what chemotherapy might work and not work. Okay, or how aggressive this cancer is going to be. So someone like Adlina can decide how much dosage to give, what the cover should be like. So these things also play a huge role.
Right, but help me understand that, right? Because my knowledge of chemotherapy is that you put the drug into intravenously, and that's chemotherapy, right? But it sounds like there's profiling of the tumors these days with genetics, and that changes the treatment plan. How does that work?
Yeah, so the pathologist will give the grade of the tumor, which is important. And also there are molecular profiling, especially like if patient has secondaries from the lung cancer, then we need to know what mutation that the patient have, because we have targeted therapy that we can use. And some of the targeted therapies actually can penetrate the brain. So if there are available targeted therapy that can penetrate the brain, then we would use that rather than radiotherapy first. But radiotherapy can be used as a salvage. So if that doesn't work, then we can give radiotherapy.
Right. And is this the use case only for secondary brain tumors, or is this even for benign
There
tumors?
are some primary tumors as well. Like certain, we can look at the aggressiveness of the tumor, and then we can decide. Yeah. But it's not so well developed for the primaries, mainly for the secondaries.
Right.
There is a protein that we looked at for primary, but largely is more molecular profiling of the secondaries.
Got it. So there is that sense of target thing in
Yeah,
a way,
and
right?
actually things change over the years. So the classification of brain tumor also change with time. So the pathologists also, has their own advancement, how to diagnose if it's low grade or high grade.
Yep.
Yeah.
Got it. And where does immunotherapy sit in all of this then? Because we've talked about chemo, talked about radiation, targeted therapy. What does immunotherapy do in all of this?
There are primary brain tumor and secondary brain tumor. For other parts of the body, there is established immunotherapy. Depends on where is the origin of the cancer. But immunotherapy per se, there are some immunotherapy seem to have some penetration, but largely we say it doesn't really penetrate the brain that well. Okay, largely. For primary brain tumor, the study is still ongoing. So we have not conclusively proven any immunotherapy that can work for primary brain tumor.
Got
itself.
it. But correct me if I'm wrong, the idea of immunotherapy here is to trigger the body's immune system to target the specific cancer cells. Is that correct?
Yeah.
Okay, got it. So help me understand and just clarify the picture, right? So every patient these days is really individualized, right? But it sounds like surgery tends to be the main line of treatment first, and then subsequently you will pair that up with, stereotactic radiation or chemo or targeted therapy. Is that train of thought in a sequence typically the case?
It is general, and I think, I'm not sure the percentage, I would say maybe it applies for about 80% of most of the tumors that occur. So the surgery comes in, sometimes we remove it, sometimes we get a biopsy, we get a tissue diagnosis, we get an accurate, do a tissue diagnosis. So there's accuracy of the cell types, etc., which lines, okay?
So I have to ask, is the biopsy invasive?
Yeah.
Right.
So we drill a small hole, but technology is such today, I can look at a scan and I can select a target and I can select an entry. I can run through the trajectory that I miss all important structures, and I can take a pinpoint biopsy, okay, and then send it off. And the pathology is so good that, with a small bit of tissue, they can tell us exactly what kind, do some genetic markings and all that as well. And then with that, Adlinda will be able to treat these things better, right? So that's the mainstay. However, with metastasis, there's a bit more variation. So sometimes the variation is that the tumor is very tiny, like she pointed out, patient with 3 metastases, but they're very small or they're very deep. So sometimes they go straight from diagnosis of a primary cancer to radiation direct with no surgical in the middle, right? But sometimes the patient may have 3 lumps in the head from the spread. One is a large one that is causing symptoms, okay? So we would take out that lump. We could give radiation straight after we take out that lump by sticking a little probe inside the brain and cooking that bit of brain while it's still open. And then the remaining couple of lesions, we send it off for further radiation to treat. So it's a combination of treatment, right? And yeah, that would be how it works. Or sometimes you just have a single metastasis and it's large, and if it's symptomatic, we go and cut it out and then we send it off for further treatment to boost the area.
Right. But certain cases can just be pure radiation straight from the get-go.
Yeah, so like I said just now, the treatment is individualized for the patient. There are many factors that we look into, and close kind of communication between clinical oncologists and neurosurgeon is very important. We cannot assume, this is inoperable. We have to ask them.
You've mentioned inoperable, and I need to ask you this question, right? So we see this in Grey's Anatomy all the time, right? Sometimes because of the quality of life of patient or whatever, you don't treat the patient, right? So are there brain tumors that you would deem inoperable and you shouldn't operate on?
This has become lesser and lesser, right? Some cases we may not operate because we've operated so many times already. That's one. Some cases we may not operate because we think that we're going to cause even more harm. Or we may actually reduce the size of the tumor to a manageable level that it can radiate. So the radiation works more effectively, right? There are not that many that we will say inoperable. Okay, so the ones that I can think of is a child with a cancer of the brain stem. Right? Sometimes we can recognize it even on an MRI scan. So we won't even suggest the biopsy. But quite a lot of tumors now would at least minimum get a biopsy, right, for us to confirm. Because sometimes I feel patients need, or the family needs closure, right? So they want to know, are we sure that's it or not, And when you look at an image, right, it is an image, but imaging is so good these days, we can be like close to 99% sure this is whatever it is, right? But sometimes they also want to know, okay, we have done a biopsy, and this biopsy says this is a grade 4, this is not good. Okay, and then they're accepting to it. But in more than, every year, there'll be 1 or 2 cases that will come through that we all think that, this is a death sentence, and then we are surprised by, what the results actually come out, and it is something that then can be treated further. Yeah.
In the case of radiation, are there cases whereby you cannot treat with radiation?
If patient cannot lie still,
You cannot shut them down?
then it will be difficult. Yeah.
Okay. But for the most part, radiation therapy is typically suitable.
Yeah, it's just we might adjust the dose accordingly. Because if it's in the brainstem, there's a limit that we would allow, the dose of the radiation.
Yeah. So got it. So, so far from what we've been discussing, it really sounds like there's a lot of new advancements in treatments. There's clearly a very strong, especially if the brain suite, let's call it, right? Multidisciplinary approach with the way we treat. There's a lot of interconnected expertise in how we treat patients these days. I want to just talk about success rates, right? As we wrap up this little section over here. Comparing to the past, are success rates wildly different now?
Wildly different. Wildly different, thankfully.
Right.
Yeah. But I just to interject a little bit for the previous, so the success rate comes from not just the skill levels and things like that, but also the technology. But also it's important, the overall facility, right? That you have all the different things. So you have surgeons who can operate. You got equipment that allows them to operate with efficiency, proper equipment, right? That they have, right? You have support that after surgery that can continue, because sometimes you can do the most brilliant operation and then you lose the patient simply because the support is not there to keep that patient better. And then you need the pathologist who has got the expertise to diagnose this very accurately. And then you need the oncology with the treatment systems that they have that can do all of this, right? So it is good if all of them can come together in a one place kind of thingy. So, but things are wildly different now. Thank God for that. Yeah.
Yeah. Treatment from neurosurgery, radiotherapy, or the systemic treatment has I think advanced quite a lot. And we aim not only to improve the control of the tumor, but also reduce or minimize the potential side effects. So in terms of treatment, the treatment or the technology machine that can give precise sort of treatment, that will be, a great sort of advantage to the patient.
Got it. So I think for people listening in today, really, if there's a diagnosis, but we shouldn't be chicken little, the sky is falling. Certainly there are a lot of treatments available today, and certainly consult with your healthcare team. And I suppose we will all agree, if you're choosing a healthcare team today or choosing a place for the treatment, we will want a robust brain suite with the advancement in technologies, the different teams, the clinical oncologist, the neurosurgeon, and also the post-surgical care that should be present as well. Would we all agree on that?
Except the chicken little bit.
Okay.
Because the dangerous thing now is that a lot of patients also go to traditional medicine, alternative medicine. So rather than when a diagnosis is made and you're told you need brain surgery or you need treatment for your brain tumor, then they decide, we should try this alternative treatment. And then what is handed to them like a gift, someone picked up early.
Oh no.
They squander it by going for alternative treatment, and then they come back in a bad shape.
What are some of these alternative treatments that you've both seen in your practice that is, for the purpose of educating the public, right, really not helpful in any way?
There are lots of herbs.
Yeah.
Some physical therapy. Sometimes it's just fate.
What can we say that does not work objectively today?
I always tell patients, if we diagnose a tumor and we think we can do something about it, let us be the first ones to give you the treatment. After that, you can do whatever you want to do. I suppose we are going by science, and we kind of believe in it, right? So give us the first bite. After that, you can do.
Right. I'm sure, Dr. Adina, you've experienced many different alternative treatments that patients opt for, right? Maybe before they even start treatment, or maybe while they're doing treatment as well. Have you noticed what works and what doesn't work in that regard?
Okay, if it works, then we would be recommending to the patient.
Right.
Because it has to be evidence-based, but otherwise, if usually patient would ask me like whether they can take certain supplement or ginseng, etc., then I would check. Depends on what treatment I would give them. I would say, okay, this will interact or not. If it will interact, then I say not to take it at the time when the patient is taking the conventional treatment, but they can take later. But whatever they take, they need also to monitor the kidney and the liver function, because all these things can also affect the liver and kidney.
Right. So the truth is, if there really are magical therapies outside, technically nobody on this table here would have a job effectively. Is that correct to then say?
I'm still quite busy.
No, but at the end of the day, if you are concerned, it's always best to present your concerns to your specialist and ask whether it's suitable or not. I think at the end of the day, we all want evidence-based care to be given, and we want you to have the best outcome possible. I want to talk about after the treatment, right? We talked about neurological deficits, and I would assume because the brain is such a sensitive organ, any mistakes in the past will leave maybe motor function to be compromised, eyesight and things like that. Is that still the case today? Are we seeing side effects of treatment in that regard, whether it's from surgery or radiation?
So from a surgical point of view, techniques have changed a lot, right? Sometimes when they are involving what we call eloquent areas, we even do them awake.
Oh,
right? Yeah.
So patients awake during the whole process?
Yeah. So my colleague, Dr. Ravi, does them awake. Yeah. Everybody thinks that famous BBC video about someone playing the violin. We've been doing that in Malaysia for a while already. Okay. But we don't talk about it, right? So the patient is talking or the patient is doing stuff while the surgeon is actually cutting out the tumor. So we can do things like that. That's prevention portion, right? But sometimes, irrespective of all that, they are left with a deficit. Okay, that's when a strong rehabilitation team comes into play. So we can do physiotherapy, occupational therapy, speech therapy, and someone to structure the whole rehabilitation so they improve and they get better. So those are the kind of things that can be done. Right? So it doesn't mean that if you have a deficit, it's not going to improve. Most patients will improve within 6 months to a year. Right? Of course, there are some that the deficit is going to be unavoidable.
Right. And Dr. Linda, from a radiation standpoint, are there any side effects?
Of course, every treatment has side effects. Even like you take paracetamol, there are, if you look at the list, so many potential side effects. So for radiotherapy, usually we will counsel the patient what are the side effects. The common one is fatigue. And then the other side effects depends exactly where the location that we want to irradiate. One of the side effects that a patient might be worried about is memory. When we give radiotherapy, especially like when we need to treat the whole brain, we can try to avoid that area or reduce the dose of radiotherapy to that area to reduce the potential side effects. It depends on where we want to target, okay? And what happened after the treatment, we would refer patient to for rehabilitation, because brain is also can be like plastic organ, so it can be improved with rehab. The other thing is if we give radiotherapy on certain areas, we would advise patient to also take care of their health in general, in terms of reducing, or good diet, exercise, and control the blood pressure, because sometimes when it's near to the blood vessels, there is a risk of, blood getting sort of smaller and risk of stroke, something like that. So we cannot avoid the side effects, but with precise treatment, we can reduce the risk of the side effects.
Right. So certainly a lot of the side effects that we would think with brain operations and treatments can be severely minimized, and even if there are, some of which can't be avoided, there's rehabilitation processes as part of the treatment, right? I think, Dr. Alinda, you've sort of eluded on my next question a little bit. After the rehab, long-term care, right? Are there restrictions imposed to the patient that they cannot do? Certain things they cannot eat?
Generally semua boleh. Okay. There are certain operations that we do where we open up the lining of the brain, especially through the nose, and then we patch them up. And so we are worried about fluid from the brain leaking through the nose. So such patients are usually told you can't fly for about 3 months.
Just 3 months?
Yeah, you can't fly for about 3 months, okay? Patients who are having seizures diagnosed at the first time, and they're waiting for surgery or whatever. Some tumors are very slow growing and we say, okay, you can come back and do it. Then they say, oh, I want to go overseas. It's not suggested, not because you cannot go, but if you have a seizure or you have a problem abroad, it's going to be 10 times more difficult to deal with it than when you're having it at home. So these are the kind of things. But as a rule, as far as I'm concerned, semua boleh lah.
But what about driving though? Because I would imagine if, let's say, the procedure was done.
So if you had seizures, you should not drive, right? You should not drive. And certain areas when we operate, you are at a higher risk of developing seizures. So we tell you, you cannot drive until 3 to 6 months. Okay. And then we tell you, okay, if you've not had any seizure, then we can think of you driving again. You can just about do everything that you want to do, but be sensible also. So if you were doing the gym a lot before, so after surgery, you can go back to the gym, but start by just like walking first and then slowly increasing the treadmill speed maybe and the duration, because you'll also be very tired, right? And unlike other forms of surgery, so if I open your abdomen, you cannot move for about 6 weeks, right? You'll have pain in the stomach, you can't move around and all that. So it's difficult. So naturally you're curtailed. But the vast majority of brain tumor patients, once we've operated on them, if they're fine, the next day they are fine. They can actually walk around and do stuff, right? And within a week they can cook, they can clean.
Bungee jump. They can bungee jump.
Bungee jump there's really no restriction. But maybe you shouldn't do it. Okay. But sometimes just don't overdo it, because it's a major surgery. It's major surgery, and they kind of forget. Especially some of these things that we do through the nose, because when you look at it at the mirror, nobody can say you have had major brain surgery. Nobody, right? And so they feel like, hey, I feel like a fraud a little bit.
So for radiotherapy, the same. They can be tired, so they have to take it slow. It's good if they can exercise, but not to overdo it. You were talking about brain tumor can affect, any ages earlier. So I had quite a few patients with brain tumor who actually goes to work and then come after work will come for radiotherapy. So they maintain their, usual sort of lifestyle. But yeah, I always advise them, if they're tired, they rest. Yeah.
Right. So it sounds like normalcy is quite realistic, right? And
it's a case-by-case basis. I've had a primary brain tumor. She's doing well still. And I know in the first time we operated on her, she even went up to Everest Base Camp or something like that, right? Okay. I can't do Everest Base Camp. But she did. And then we have subsequently operated a couple of times because the tumor recurred and she's fine. Gradually, you can transition.
But it sounds like it doesn't rob you of your original life, right?
Well, to a lot of patients, yes, it doesn't.
Yeah. I mean, it's a spectrum.
Yeah.
Majority of patients, we can treat and they can return to some sort of normalcy. But there are, of course, patients who are really have aggressive tumor, quite bad. We cannot just put a sort of blanket statement. But there's always hope in terms of trying to treat and control the cancer. And once we treated or during the treatment, we try as much as we can to continue with rehab and things like that, so that patient can maintain their lifestyle or have a fairly good quality of life.
Got it. So when it comes to long-term care, right, after the surgery, after the periods of radiotherapy, for example, is it very common for a lot of brain tumors to reoccur?
It is relatively common simply because The brain is different from, I always tell my patients, if you have a tumor at the end of your finger, I can chop your whole finger off. I can even chop your whole arm off, right? And say it's not going to spread. But when we do brain tumor surgery, everything is next to each other, right? In other operations, the pathologists, the surgeons will cut in such a way that they'll give you what's called a clearance margin, right? How far away from the tumor, and then the pathologist will confirm that you have got this clearance. In brain tumor surgery, we cut from inside out. We don't cut from outside in. So there's no clearance margin. We never talk about clearance margin, okay? We never will tell the patient, I can get 100% of this tumor out. Never. Because even if the post-op scan looks beautiful, I will still tell patient, if you ask me, it's possible that it can come back. And that's why you need long-term follow-up. And if it comes back, today with radiation, radiosurgery, a lot of these tumors can be managed with radiation. But sometimes patients live 12 years, they don't do a repeat scan. And then what can I do, right? Yeah, so that can happen. But when you take them out, we actually follow them up fairly closely. Scan 6 monthly, followed by yearly, followed by, depending on what kind of tumor it is, how aggressive it is. So sometimes we go back and take it out. There are patients who have been operated on 3 times, 4 times.
Is there a limit of how many times?
No. Technically, no.
Yeah, that's a very important question. For low-grade brain tumor or high-grade brain tumor, they should sort of continue to have this surveillance. Or you can say it's like secondary screening.
Yeah. Aggressiveness depends on the grade of tumor.
Okay, got it. So if it's an aggressive tumor that we've identified, I would assume that the follow-up duration will be, between each visit, will be shorter.
Shorter, yeah.
Right. It clearly sounds that there are good news on the horizon. And even where we are today, there are clearly good treatment modalities available for patients already. We spoke about telling the public, educating the public today that if you're concerned about brain tumors, you can certainly look out for symptoms. But I want to hear it from the both of you, right? If there's a key message that you want the audience to remember as a takeaway, what would that be?
I want to emphasize, like you said just now, brain tumor is not a death sentence. There is hope. There are treatment that we can use to control the tumor. Some cases can sort of give long-term survival advantage. Yeah.
If you have neurological deficit or things that you think is electrical in nature and is progressive, go and get help. Just check it out.
Go and get help.
Yeah.
All right. Dr. Alinda, Dr. Vicky, it's been a pleasure. Thank you so much for coming on board.
Thank you.
Thank you. Our pleasure.
If you've been listening in and you find this session really interesting, don't forget to leave a like. And if you think this would impact somebody you know, please send it to them. If you have any questions or any topics that you'd like us to cover in the future, feel free to comment down below.